Well, a couple of things really is just again to remind everybody where we are in terms of the disease and how delicate a balance we are currently operating with. Now, again, there are always people joining in at various times, so let me just remind everybody what we're dealing with. The COVID-19 is one of the sort of coronavirus diseases. It's a large group of viruses that cause respiratory illnesses. So it's not new. I emphasize that. Coronavirus is not a new virus. The common cold is a coronavirus. What we are seeing is a novel coronavirus coming into the respiratory spectrum. And it's a condition that is causing a certain amount of medical conditions and diseases. We have seen the coronavirus manifested in a more severe respiratory illness in the past with SARS in 2002-2003, which is severe acute respiratory syndrome, which is why it's abbreviated SARS. And then you had another outbreak of a coronavirus respiratory illness, a severe one called MERS, which is Middle East Respiratory Syndrome in 2012, 13, and in 2015. What makes this one different, which is COVID-19, a coronavirus disease that came in 2019, is that it is much more contagious. And I think that's really why I'm gearing into the whole question of where we are in the whole story, so we don't get too misled or too comfortable. The thing about the COVID-19 or coronavirus 19 disease is that it's a corona-type virus, which means it gives you a respiratory illness, but it's very contagious. So the R naught, which is the rate of doubling spread, is very high. So the R naught for the coronavirus is 3. So they think every time one person spreads it, they spread it to 3. And then that means 3 spread it to 9, 9 spread it to 27, 27 to 81, 81 to 265, and so on. So the rate of the doubling time is very fast. The biology of the virus gives a very fast doubling time. The other dimension about the virus is that it has a relatively low mortality, in the sense about it's operating about 1 to 3%. That is a variable number because we actually don't know the number of people getting it. Because 80% of the people who get the virus actually have a mild illness. And some people don't even know they got it. So the denominator or baseline remains uncertain. So if you thought 10 people got it and 2 people died from it, then it's a 20% mortality. But if it was really 100 people who got it and you have 2 people dying, that's a 2% mortality. If it's 1,000 people, it's 0.2%. The problem is we don't know what the baseline is. We don't know if the number of people who actually have got the virus was the recorded 6,687, which I think is the current number, or if it was really 60,687. So the baseline becomes the problem. But that being said, what we do know is that about one out of 5 people who get the disease get it very severely, requiring hospital care. And of those, you'll get another 5%. So 5% of those would have a severe disease requiring respiratory support, like a ventilator. And of those who require respiratory support, half of those people will die. So the current numbers, I think last time I remember seeing, was about 70 people had died from the virus. Most of these people who have died are the elderly or people who have some coexisting morbid disease. So, if you're elderly, your immune system cannot actively fight disease. And if you have comorbid diseases, diabetes, blood pressure that's uncontrolled, and rheumatoid and so on, then your immune system is already compromised. So people who get that disease, when they become respiratory compromised, getting on a ventilator, their mortality is higher. So that's a quick summary of it. Where we are to date is through a containment strategy, we've been able to bring the incidence of new viral cases down very low, substantially low. As a matter of fact, the predicted trajectory that we had initially was going to be matching that of Spain, which was dramatic at best, Spain and Italy, or America, which has taken a very exponential movement of the curve. But because of the containment strategies, our viral incidence is very low. I think right now, the last time I think was reported, we probably have about 25 cases throughout the entire all of Australia, which is that's 25 new cases, not people who necessarily have got any illnesses. Of those who have died, I think we're just looking at the area about 20 or 21. So because of the containment strategies, the result in the Australian situation has been extremely good, and for that we congratulate the government and those who took part in that, and the people who supported the strategies. But I want to hasten and add two things to that story. Number one is that's a containment strategy, that is not a treatment strategy. There is no treatment currently available. In terms of the approach to treatment, the treatment was going to be in the range of a vaccine, which is currently ongoing. In England, they're testing a vaccine and looking at drugs that might specifically target the virus. And one drug combination that that was being in France, there was an observational report that the combination of hydroxychloroquine, which is Plaquenil, used for rheumatoid arthritis, and azithromycin, which is an antibiotic, was giving initially good results. Unfortunately, a number of ongoing studies and one recently published show that the mortality is higher by using Plaquenil and azithromycin, so that those studies have eventually been terminated, and that particular line of approach is not really being followed anymore. So that particular strategy is out. They have a second line of research going on using the HIV, anti-HIV, antiretroviral drugs, which is lopinavir and ritonavir. I think those are the two they're using. Yeah. So they're using those two drugs, which are used for HIV, human immunodeficiency virus, or AIDS, to try and see if they can reduce the incidence of or recovery of the patient and reduce the incidence of mortality. So the studies are ongoing. There is some early suggestions that it does seem to reduce the incidence of the patients going on to ventilation, but I must admit it's a very, very small study. And but the major problem with the HIV or antiretroviral drugs is side effects. So on one hand, they have pretty horrible side effects when you use them, and so the studies are ongoing. But I would say of right now, there is no specific drug. Where it comes to the vaccine, just to give you an update on the vaccine, there's an English group that think they've found a vaccine for the virus. They're currently testing it. They've got 500 people who have put their hands up for it. That's in England. The big problem with it is that there is no way to test them for it. So you're basically given the vaccine and waiting to see how they respond to the vaccine in terms of an immune response. But what we're not doing is taking them and putting them in the heart of a COVID virus infection and say, well, you go sit among people who have the disease and see what happens. That'll be unethical. So the current thought is that at least it'll take about a year to evaluate whether these people came across the disease, sort of coincidentally or fortuitously, depending on how you view it, and whether they were able to be protected by it. The third element that is being considered with the virus, the vaccine, is that we don't know if when somebody gets the disease or if they get a vaccine, whether the protection is temporary or long-term. So there are some people who have gotten the disease supposedly again. There's some reports that say they don't think they really had the disease or not, but I think that's just scientists trying to calm the people. These are people who had confirmed COVID virus and they have been reinfected by it. So there is some possibility that even if you have been exposed to it, there is a strong possibility that if you got it again, you might be if you were exposed again, you might be reinfected. So that is just a sort of quick update as to where we are. In terms of how the government's approaching the strategic approach to it, is that they're trying to open up some more of the commercial spaces to allow people to go to work, but at the same time maintain social distancing. I think that's a reasonable strategy to approach it. I think it'll be very much a mistake to think that because the incidence of coronavirus is gone down. I think in Queensland we only had one case. I don't even think they had one case yesterday. The day before we had one case. In many of the states there are no cases reported. The highest incidences are still in New South Wales, but their numbers are going down very dramatically. It will be a mistake, ladies and gentlemen, in my judgment, to think that that means that the problem is solved. I think we're going to be doing this social distancing for a long time. That'll be my view, in the range of 6 months to a year. I don't think there's any way around it. Unless one more thing happens that could change that, and I'll tell you what it is. But in the meantime, they will allow people to go back to commercial spaces that are large, where they can still have social distancing, like how we go to the supermarket or you go to the pharmacies and so on. As long as that space is big enough, they will allow. I think they will allow restoration of the use of commercial spaces so that they can get the economy going again. The other thing is that I understand they've opened up the beaches. So the beaches are now open for exercise, and that's a very specific reference. As Lauren was saying, you can go and walk on the beach and so on, but you still have to maintain social distance. So those are the quick updates. Let me just comment on one more thing in terms of maintaining social distancing as the relevance of it. There is no treatment on board. It does not exist. The coronavirus outbreak started by one person in December of 2019 in the Wuhan district in the Hubei province. One person got the coronavirus in December of 2019, and literally within a month, within 6 weeks, the entire world got it. So that is the kind of infectivity we're discussing. So right now, whereas we could control the external borders, in other words, we can stop people coming in, or when they come in, we get them mandatory quarantined. All you need is one person. So if we got rid of every coronavirus case, it was 0 for a week or 2 weeks, and you thought, well, we've contained it, no more incidences of the coronavirus. All you needed to have was one person coming into the country, literally just one, and the whole problem starts all over again. So I just wanted to say very quickly that the strategy for coronavirus is going to be for a long time social distancing. I'm not entirely sure at what point churches will be restored. I have my doubts that would be within 6 months. I have my doubts, where we could go back to regular church services. The only thing that can intervene on that is the threefold strategy, which I call the triple T: testing, tracking, and treatment. Well, there's no treatment, but you can isolate and you can manage people who've gotten it. But what if they come up with a test that is quick, a rapid onset test? Some tests are on board looking at 4 hours, in which they can give you a response, an antibody test and so on, but they're not reliable. But if they came up with a test that they can test you when you come into the airport, or perhaps when you're boarding the plane. Certainly when you board the plane and when you land into the airport, they can give you a rapid test that was reliable, and they could say to you on spot, you don't have the virus, then they could let you go free without getting mandatory quarantine. But until such rapid testing comes in place, they're going to have the control of the external borders, the immigration borders, and I suppose that until the incidence of coronavirus is 0 in Australia, which will extend over a period of 2 weeks, they will continue to have the control of internal borders. So I don't think we're going anywhere with this for a while. I would say like 4 to 6 months at least, probably more like a year. So it is something that we need to get accustomed, get our heads around, and make sure that we take appropriate steps. Now, the last thing I'd say, and then I'd open up the floor to questions, is that because there is no treatment, the strategy for containment is still the same. Social distancing, self-isolation. Well, it's not self-isolation, it's not mandatory isolation if you got it. But in terms of your internal hygiene factors, it would still be the same. It will be the proper hand washing with soap and water or with alcohol, proper disinfecting of the surfaces, external surfaces, and that means in home and at your place of work. Or the one that we could get caught out is if you go to a shopping center or something, and then you're walking down the escalator and you put your hand on the rails. You put your hands on the rails. If there was a virus, you could pick it up on your hands, and then you put it on your eyes or your face, any mucous membrane, and then you just get it. So having hand sanitizers is a good idea. There is a new sanitizer that is coming on board, about to be distributed in Australia, which is meant to give contact control of the virus for up to 2 days. That's supposed to be going into supermarkets pretty shortly. Can't remember. I think it's called Sanitaire or something. But anyway, something like that you'd want to get so you can get contact control of the virus. And then, of course, the third element, of course, is if you do happen to have any symptoms which suggest that you may have the disease, you should present and get yourself tested. So the three elements is testing, tracking, and treatment. The testing part, we said, still has to be done. Tracking is where Lauren has already commented on that. And I take respect to the lawyer because she's the one that looks at it. In my opinion, right now, as long as the legislative hurdles are crossed, we are tracked right now. You go on your satellite navigator, they could tell you where you are. Almost every app that you put on, including Zoom, asks for my name, my address, my date of birth. The amount of information that we are putting on whenever we just put a simple app on our phone is incredible. So I take the point that Lauren makes as a lawyer, that we ought to be very careful about the information we actually putting out when we go on Facebook and all that sort of thing. That information is all available. That being said, the fact that everybody knows where I live, what my telephone address is, and how to contact me, the mobile phone tells me how long I take to go to work, I'm probably not as skeptical about the use of a tracking system that would allow me to identify when I've come in close contact with a person. Whether that's actually needed with our cases of COVID going so low, I'm not entirely sure. And finally, as we said, still using common sense. Just be sensible. If you've got to think of it along two lines. If you get the disease, there is a chance that you could succumb to disease, and there's a chance beyond that, meaning with major respiratory symptoms, and there is a possibility you could end up on a ventilator and die. Or two, it is quite possible that you could give it to someone else. You can give it to a family friend, you could give it to your husband, to your wife. Children are not as susceptible, but children can get it. There have been incidences of children and young adults dying from the COVID virus. So I don't think that one can just be very cavalier and blasé about it and say, well, I don't care, I don't get it, so I don't care who else gets it. I think that's going to be a mistake. So I think you still have to exercise social distancing. You still have to use very good common sense. And for now, I think, ladies and gentlemen, brothers and sisters, we're going to be meeting on a Zoom table for a little while. Get used to the technology. I think this is going to be the way we're going to be meeting for the next 4 to 6 months at least. But God is doing a new thing. I like that text. The Bible says God is doing a new thing. And I shared with Pastor and the rest of our team as well. I think out of this, whenever it emerges, maybe we will keep more in contact because of this Zoom platform. Maybe in the past where we weren't contacting people during the week, we wait only for the Sabbath meetings. This might be an opportunity for us to meet during the weekdays and really have a different level of fellowship than we had before. So that's basically it, Pastor David.
Thank you. A couple of quick questions that have been posted on the Q&A section for both of you. I might just start with you, Tony, with a health question. I'll come back to Lauren with a legal question, and then we'll start to wrap it up. Tony, one of the questions was that there is some evidence to say that the COVID-19 virus is not just impacting upon the respiratory system, but there is some evidence that it's actually impacting there are examples of it impacting upon other parts of the body, the heart and even the brain. Have you got any comments on that the virus is not just impacting in some cases just solely on the respiratory system?
Yeah, thanks, Pastor. Good question. The virus targets the respiratory system. That's its main target. The problem we're seeing is that the disease that is following is not because of is not the virus. The virus is creating an immune reaction. That's why it is called SARS or MERS in the past. But the COVID virus is a SARS. It's an acute respiratory syndrome. It's one of those severe acute respiratory syndromes. So what happens is that when the virus affects the cells of the lung, it affects the surfactant cells, which are the type 2 pneumocytes. it causes the body to release an immune reaction, a response. So a number of mast cells, T cells, and so on. The body reacts to the virus as an invader. But the problem with it is that as it acts as an invader, it gets a hyperimmune response. So the immune response is very exaggerated. And you get an inflammatory response throughout the entire body. So it's not the virus so much as attacking the brain or the heart or the lung. What is happening is that the inflammatory response, the response of the body to the virus, creates problems that affects the brain, the heart, and the kidneys, and so on. So that for example, when you have a virus and the immune system responds, it sets out a number of chemical mediators, interleukins, a number of substances that cause the tissues to dilate. So the blood vessels dilate and your blood pressure drops. That's called an inflammatory response. Now the kidneys, trying to respond to that, will squeeze the arterioles because it wants more blood pressure. Everything wants to go to the heart and brain. It wants to supply the blood and heart. So the blood vessels everywhere starts to squeeze the organs in order to get more blood to go up to the heart and the brain, because it is suspecting that if you lose blood supply to the brain and the heart, you die. So that is what causes the problems. As it squeezes the blood to the kidneys start to fail. As it squeezes the blood to the lungs start to fail. As it squeezes the blood to the coronaries, the heart starts to fail. So the answer to that, it is not the virus of itself attacking those organs. It is the way the body responds to the virus in this inflammatory response is what gives you the disease that affects the brain, the lung, the heart. Now, it's not unique. When I was doing cardiac, we were doing open heart surgery and lots of things with the heart, lung transplants, and so on. We noticed that a number of patients, when you put them on the bypass machine, they would come off and go into this identical thing that we call, what we're terming as SARS. It's really called ARDS, Adult Respiratory Distress Syndrome. That was just a response of the person going onto a bypass machine and the immune response, the immune reaction becoming very florid. And you had the identical thing on post-bypass for some people, as we see with severe acute respiratory distress syndrome. So it's not the virus doing it, it's the response of the virus is attacking the lung, but what we see coming on, leading to the ventilator and so on, is the response of the body to the virus. It's a flare called an immune response, and that flare is what's causing. Now, to close that section, so I'll give Lauren a chance, is that how would you strategically approach it? My advice would be to increase on your antioxidants in your body. Because your immune response is basically swamping your antioxidant supply, you need to increase the amount of antioxidants that's in your body. So that's why last time I recommended the use of vitamin C, the use of vitamin B. Even though it's not an antioxidant, it works with the immune system in terms of protection. I use resveratrol. Resveratrol is coming from the skin of the red grape. And you get it from drinking red wine. Now, we don't drink red wine, Pastor. At least we're not supposed to. But the wine does not, the alcohol does not help you. But where you get the protection is the antioxidants that comes from the skin of the red grape. You don't need to drink wine to get it. You can buy the product called resveratrol. Resveratrol is a concentrate of the skin of the red grape, the antioxidants and the phytochemicals in it. So you can do a number of these things that will effectively protect your immune system from the flare response. And I tested it when I was doing when I was in charge of the cardiac unit, the open heart surgery. We would put patients on vitamin C and an antioxidant, selenium and antioxidants before we put them on bypass. And those people that were put on the antioxidants had a much lower incidence of the acute flare response called ARDS than patients who were not on it. So it's one of those things that we recommend that you could certainly do to help yourself in this hour of need.
And I'm assuming, Tony, as we go to Lauren with a couple of questions, I'm assuming that to get that particular antioxidant, we can just eat red grapes.
You could, but Pastor, it doesn't give you the concentration. So in an extract of this, because it's not concentrated, it's just the skin. So when you use grape juice or you drink red grapes, it's not concentrated. It's like the difference between drinking an orange and drinking orange juice. Orange juice concentrates a lot of juice into one space, whereas an orange is just 60-70% water. So when you use the alcohol extract of the skin of the red grape, which is put into a capsular form, you get a very concentrated concentrated quantity of the antioxidant in one place. And then when you take it, it's like effectively, like the tablets I take, when I take one of them, it's effectively like taking 5 glasses of red wine. Now, I don't have to drink the red wine. That way I don't get in trouble with the church board. But I can drink my 5, you see, I can take my 1 capsule and the church board wouldn't put me in trouble, Pastor, and I'm okay. And I still get I get the same as drinking 5 glasses of wine. So it's concentrating it. And yes, you can get it, grape juice, but it's just you don't get the concentration. And my advice would be that in this current climate, because you want to protect yourself by loading yourself up with a bit of antioxidants, it's much better to drink the concentrated one. One which I would recommend, and I can only recommend this without research. So there are things I tell you with research. The ones I told you, vitamin C, selenium, zinc, vitamin B, and so on, copper and so on. Those are all well documented. I can provide research for you very clearly on that. One which I think is worth looking at is tea tree oil. Very much worth looking at. The only thing with tea tree oil has been shown to be antiviral, it's shown to be antibacterial, it's shown to be antiprotozoal. It's got a gross potency, gross efficacy against a number of organisms. The only thing with tea tree oil you have to be careful about is that the ones that you can't take orally. Not all of them you can use orally. There are 1 or 2 products you can take oral tea tree, where they have extracted out the polyphenol and the oil compounds. But the one that you just buy as an oil, you can't use. That's only a topical. That's only for skin. You can't use that internally. So please don't take this to mean go and buy this oil and take it internally. You'll kill yourself. It's got a number of lignins and chemicals that are very dangerous. But there are a few products out there that you can use this tea tree oil. They've extracted the oil as an oral formula. And if you can get something like that, I would strongly advise that you consider using that. If I had the money, I would do some research on it. But the point is, I say that one just on a biological spec, if you understand, as opposed to research. The others I told you on research, that one's a biological spec, that I know the spectrum control of tea tree oil. It covers many bacteria, viruses. They haven't found a virus, a bacteria, or a fungus, or a protozoan that tea tree oil will not kill. That's why they use it for your nails, and they use it for your fingers and skin and so on. But just bear in mind, please don't go away and take an oil and take it orally. You will die and put me in trouble. There are some oral preparations of it, and those would be well worth having in case you do happen to succumb to any of those diseases.